So I've been rather at the centre of getting this document produced and put through Greater Manchester Medicines Management Group. And I appreciate that, yes, we can all read, but I thought it was worth just running through the flow chart here and giving you a bit of commentary on some of the aspects. So as you can see, it's a lipid management pathway for the secondary prevention of cardiovascular disease. So if we start in the top left corner, we're looking at people with a confirmed diagnosis of CVD. So that's the likes of stroke, peripheral arterial disease, angina, heart attack, or have had revascularization. And, excuse me, it is recommended that the lower cholesterol, these people take 80 milligrams of atorvastatin daily or an alternative high-intensity statin. The definition of high-intensity statins can be found in the NICE clinical guideline number 181 for cardiovascular disease. And they should take those statins either on their own or with, for example, ezetimibe. And the numbers that we need to remember for secondary prevention are target lipids of non-high density lipoprotein cholesterol of less than 2.5 millimoles per litre, or their low density lipoprotein cholesterol of less than 1.8. And those targets are in the AAC National Lipid Pathway, which is the very first of those guidance documents in the first box on the right side of the pathway. National document, and that's actually hyperlinked. I meant to say also that this pathway is on the GMMG website. If you go to the home page, over towards the right-hand side, there's a green box, it says clinical guidance. If you drop that down, there's clinical guidance and pathways, and you'll find this pathway and some other supporting documentation there. So the key thing is to ensure that people, of course, are actually taking their statins and ezetimibe and to lower cholesterol. But of course, we know that some people cannot take them. They say they have side effects. And the key thing here is to try and maximize at least the dose of statin that a patient can take. So again, in the guidance box in the top left, we've got a link to a national statin intolerance pathway, which provides lots of good information about defining statin intolerance and stopping and then re-challenging patients with statins in terms of restarting with a lower dose and going slowly as well. So the aim is to get patients to take at least as much statin as possible, because there is the most clinical patient-orientated outcome evidence for statins and ezetimibe, and also they are actually cheap. So that's win-win, as it were. However, in some cases, of course, people will not get to those target lipid levels, and we move into the diamond-shaped box on that pathway on the left side. So if their LDL cholesterol is less than 1.8 or the non-HDLC is less than 2.5, then that's an affirmative, move down the left side, and that's great. We've done what we can for these people, and we just need to review them annually and make sure they keep taking the tablets, as it were. However, if they don't reach those target levels, then we go to the right of the diamond. And first thing to do, of course, is to actually check that people are actually taking the tablets, which quite often they don't. So we do a lipid, an LDL cholesterol measurement. So we do require a blood test. That's the orange box. And there's some extra advice around that orange box on the right of the document, which says that we can either calculate LDL cholesterol from a non-fasting or a fasting sample, but we would recommend using a fasting sample if the lipid levels are within 0.2 millimoles of a treatment threshold. However, we know that some laboratories in Greater Manchester can now do direct LDL cholesterol measurements, and we only need to use a fasting sample. A non-fasting sample, beg your pardon. And the 0.2 recommendation is not applicable in that case. If I look at the right, I've started the right side of the 3 down arrows from the orange box, then if LDL cholesterol is equal or greater to 3.5 or 4, and the exact definitions of those are in the green box on the right side again, and these come from NICE's technology appraisals on 2 drugs of PCSK9 monoclonal antibodies, which are called alirocumab and evolocumab. Patients are in this group. We can offer them a choice, which is either they can be referred to secondary care for initiation of one of those PCSK9 monoclonals, or we can actually offer them this new lipid-lowering drug, inclisiran. I'll say a little more about in a second. And that's really when we go down the second or the middle pathway from the box. Just also mention that those injectable PCSK9 monoclonals, they are generally have to be administered fortnightly, or they can in some instances be pushed out to every 4 weeks. Patients can be taught to self-administer them, and they will probably be supplied through a home care supplier. So patients don't actually need to go to the hospital to get a prescription every month, or receive them every month, as it were. So if LDL cholesterol is greater or equal to or greater than 2.6 millimoles, then we are meeting the NICE recommendation for consideration of inclisiran. And that is an injectable drug which is given sort of time now, having a follow-up one in 3 months' time, and then 6 monthly thereafter. So providing people come back for their injections at the right time, then we know that compliance will be very good. At the present, at least, inclisiran is only licensed to be administered by a healthcare professional, and it's not for patient self-administration. So they have to go back to their GP practice at those required intervals to receive further doses. It's a very new drug, and in discussing with patients which lipid-lowering therapy to use, we have to remember that while it has some shorter-term clinical studies which have shown that it's really effective at lowering cholesterol, there's actually no long-term outcome evidence for it yet. And so, because there's still potentially question marks about longer-term safety, we recommend that patients on inclisiran do have liver function tests before starting, and then at least annually thereafter, together with a full blood count annually as well. On the left drop-down pathway, if LDL-C is between 1.8 and 2.6, then the patient is not eligible for any further pharmacological intervention, but we should at least know that we are doing much of what we can in order to reduce the risk of a further cardiovascular event, and just encourage them to keep taking the tablets and adopt healthy lifestyle and dietary measures. Just a couple of things to say about the last couple of white background boxes on the guidance section. Excuse me. Patients should be referred to lipid clinics if their triglycerides are shown to be 20 or more millimole per litre on a single measurement, or more than 10 on 2 measurements, because they're actually at a higher risk of pancreatitis. Complex cases with multiple morbidities should also be referred, as should anyone with a total cholesterol of more than 7.5, or if their non-HDL-C is greater than 7.5. These might be people with familial hypercholesterolemia. And in the last box, relatively recently, NICE also issued excuse me, some guidance for a drug called icosapent ethyl, which is under the brand name Vascepa, and that is indicated for people with raised triglycerides and secondary prevention with some other requirements, but that would be recommended from a lipid clinic, although after that recommendation, we regard it as suitable for prescribing in primary care. Next slide, please. Thank you. So just a couple of notes about the prescribing, ordering and cost of inclisiran. So the first green box there is exactly the recommendations from NICE in its technology appraisal for the use of inclisiran, and we've given it a green background because we regard inclisiran to have a RAG rating of green that is suitable for primary care prescribing. And this reflects the NHS England approach, which very much intends that inclisiran is prescribed in primary care. Some people may be prescribed it from secondary care, at least initially, and GPs would be asked to take over prescribing. We think that's reasonable. And a very key point to remind people is that even if they are prescribed inclisiran, or indeed the monoclonals, then, excuse me, then they continue to take their statins and ezetimibe. In terms of the price of it, NHS England or the Department of Health have an agreement with the manufacturer that it will be charged to primary care at £45 per injection. And when primary care administer it, they put through a submission to the Business Services Authority, and it will be reimbursed at £55. And the £10 difference is effectively the practice's professional fee for administration. Thank you.